We're going to go ahead and get started. Welcome to today's seminar series from Hopkins Center for Global Health, Strategies to Support the COVID-19 Response and LMICs. We have a really interesting topic today, and it's one that's been much sought after by many of you, which is contact tracing. And we have our expert, Emily Gurley, who's going to talk to us. Emily is an associate scientist in the Department of International Health under the Division of Global Epidemiology and Control. Some of you may know her for her newly released famous Coursera course that apparently has 230,000 followers. So it'd be impossible for her to talk about a whole course in 20 minutes, but I'm hoping that we'll be able to get a brief introduction into this space and also an opportunity for those of you who are now responsible for contact tracing within your respective countries to ask some focused kinds of questions to our expert. I see that you're all using the chat function. Thank you so much. So feel free to introduce yourselves, because what I hope with the chat function is that you'll identify other colleagues in the country or in the same space as you. And it's an opportunity for you to reach out to each other as well. I will take questions and answers at the end. We'll aim for about 15 minutes of Q&A. Please use the Q&A function so I can keep track of all the interesting questions you have for Dr. Gurley. So without further ado, I'm going to hand over to my colleague. I hope you enjoy this session.
Thanks for the introduction, and it's a pleasure to be with all of you this morning, at least Baltimore time. So let's get right into it. A lot of what I'm talking to you about today does come from the course, but I've sort of picked out some of the more important pieces that I think could be useful for our discussion, and things that are really unique to contact tracing for COVID-19. So why do we do surveillance? Why do we look for cases of any disease? Well, it's because we need to take action, right? So identification of a case through a public health surveillance program implies that we are taking action somehow. It's not a research activity. It's something that's done for the good of public health. So the same is true of COVID-19. When there's a diagnosis, there should be some public health action that accompanies that diagnosis. And there are a couple of things specific to COVID that are related to contact tracing. One is supporting the person who is infected, making sure they have access to medical care, social services. One day, hopefully also offering treatment. We don't have a lot yet to offer, but hopefully that will be coming through something that's accessible to everyone soon. And importantly, we want to take action to limit contact with other people, right? Because we want to prevent infection. That's one of the best tools we have. And then we also take action to try to identify people who may have been infected by that case. Again, there is a public health benefit here, notifying them about their exposure, offering other social services that they may need. One day, maybe even offering treatment. Again, not something we have now, but could have in the future. And limiting their contact with other people, again, to try to stop the spread. So just to bring this all together to say that, when we, from a public health perspective, surveillance systems to find people with COVID-19 are there because we have an imperative to take some public health action. These are the kinds of actions we're going to take. So let's unpack this a little bit more. So the whole point of contact tracing, and this is nothing new. Most of you already know about contact tracing, maybe already use it for other diseases. So the premise is the same here. If we can limit contact between people who are infected and others, then we limit opportunities for the virus to be transmitted, right? So contact tracing is all about limiting the opportunities for the virus. Let's walk through a little bit what this looks like in terms of timeline. So over on the left side, well, at the top of the slide, you can see the calendar days. So we're going to be walking through time in this series of slides. And on day 0, on the left side, you can see that someone is infected. So the incubation period, which is the time right from exposure or infection, from infection until symptom onset, is typically 2 to 14 days, but the median is 5 days. So within 5 days, most people infected are going to already have some signs and symptoms. So we're talking here about symptomatic folks. Asymptomatic folks are a little bit different, but let's just think through this from the simplest perspective here of someone who is going to develop symptoms. So that person then, let's say by day 14 latest, they develop symptoms, and their illness is the blue line. So mild illness, they could be infectious for up to 10 days or so. For severe illnesses, they're going to be shedding virus longer because their body's having a more difficult time controlling the virus replication. When we think about stopping transmission, signs and symptoms are important, but what we really want to know about is the infectious period. So when is that person infectious and able to infect others? And so we know that as long as they're shedding, they can infect other people. We also know that they are infectious up to 2 days before they became sick. And there's some evidence to suggest that they're most infectious on the day they become sick. So this really proves a challenge, and is why the virus is so good at moving so quickly around the world. So let's say that patient had contact with someone else, and they infected someone else on the day they're most infectious, the day they became ill. So you can see that person now here on the screen. And let's assume that they also have a 5-day incubation period, which is the average. That means that they are, and you can see in yellow here on the timeline, infectious 2 days before. So they're infectious then, just within a few days of contact with the case. So if we want to find most of these contacts before they become infectious to stop transmission, we have a window of opportunity that's quite short here. And it's just within a few days. So this is one of the reasons why the scale and the speed of contact tracing for COVID-19 has to just be totally different than contact tracing for other diseases that we often use contact tracing for, like TB or other sexually transmitted diseases, because this window of opportunity is quite short. I assume that you're all familiar with this concept of the reproductive number, which is how many people will one infectious person infect, given that everyone around them is susceptible. It's a good way to measure how fast a disease can spread, because the higher the reproductive number, more people that will be infected at each step of the outbreak. But you can see the difference between an R naught of 1 and 2 is quite different here. So, at 1, the outbreak is just going to continue on. Each case just results in another case. Now, for COVID-19, the reproductive number is usually 2 to 3 is our best guess. So that trajectory is exponential. So the curve goes up very quickly if we don't have any interventions. And you can see that here with the R naught equals 2 red line. But I think it's important to not think about contact tracing as an all or nothing kind of endeavor, because, I'll just go back to the slide, right? The difference between R naught of 2 and R naught of 1 is very different in terms of total case counts. So here's another way to look at this. So this is how, at each step, an outbreak with an R naught of 2 would grow. But if you can stop just one infection at each of those opportunities where transmission is happening and prevent just one person from being infected, as you can see here, you can have a huge impact on the total number of cases in any outbreak. So contact tracing doesn't have to stop all transmission in order for it to be really useful. This is just a toy example, but something that I know many people are interested in thinking about. So let's talk about just some basic definitions for contact tracing for COVID. So a case is someone who has COVID-19. Usually this is through a positive lab test, usually a PCR test showing that they have an active infection. There are some contact tracing programs that could use a suspect or a probable case definition. So maybe it's someone who's been exposed, who developed signs and symptoms, and you would treat them as a case even if they haven't been able to be tested yet. Contacts, now who is a contact? So a contact is someone who has had a potentially infectious exposure to that patient. So we already talked about, what that, something about the timeline of when that might be. It would be someone who's had contact during their illness or the 2 days before their illness began. And there are 3 types of contact categories that we think about. One is physical contact. So if you had physical contact with someone, that could lead to infection. The second is someone who has been a close contact, is a way to think about this. And it's someone who's been within a 6-foot distance of you for 15 minutes approximately. Currently, CDC recommends 15 minutes or more. Some places are using 10 minutes or more. Some could use 30 or more. And that, there's some flexibility there. We don't have a strong evidence basis for the number of minutes. But the 6 feet comes from really the distance that droplets that come out of our mouth can travel. So coughing and sneezing can spread droplets up to 6 feet away. So that's where the 6 feet comes from. Of course, if you're wearing masks, and everyone is wearing masks, that changes this. So this close contact and these distances and timelines are relevant for scenarios where no one is wearing a mask. There's also a concept of approximate contact, and this is someone who may be more than 6 feet away, but in the same enclosed space, like room, with someone for an extended period, so 2 hours. So let's say you're in an office with someone and they're more than 6 feet away, you don't have physical contact with them, but you've been in the same room with them for a number of hours. That could also be considered a contact in some places. Again, if everyone's wearing a mask, that changes the scenario. So wearing masks does reduce our contacts overall. But those are the kinds of contacts that you would want to find who could be infectious. And just to briefly review, what are the definitions of isolation and quarantine? Sometimes they're used interchangeably, but they're really 2 different concepts. So isolation is keeping sick people distant from healthy people. So that's what someone who has COVID-19 does. So they're separated in the hospital to limit transmission. They're restricted within their home, hopefully to reduce transmission in the home. And they should be isolated for the duration of their infectiousness. Ideally 2 days before symptom onset, but that's really difficult to do, right? Unless you found them before they develop symptoms, right? That's what contact tracing can do, find cases before they develop contact. And they should be isolated from others until they stop shedding. Our best guess of when that is at least 10 days after illness onset. If all their symptoms are improving and they haven't had fever for 3 days, they're probably not shedding anymore. Quarantine is restricting the movement of people who are healthy. They may have been exposed, but they don't have a diagnosis. And usually contacts are asked to quarantine themselves or isolate themselves from other people, have no contact with others for 14 days after the last exposure to a patient. And that's because, again, that 14-day window is when someone could develop signs, symptoms, and infectiousness following exposure. That comes from the incubation period. So we talk about contact tracing. So now you know sort of the basics of what it does and what we're trying to do. This slide just shows you the basic steps. So first, you're gonna, and it's important to point out here in the United States right now, contact tracing is being done primarily by phone, and that's because of how quick it needs to be, and also because visiting patients in their homes has some risk for transmission. So we We want to go do it by phone as much as possible. So you're introducing yourself first to the case, right? Getting basic information about them, figuring out when their infectious period was, asking them about their contacts just during that infectious period, asking them to isolate themselves, then finding their contacts. So calling them, asking about their symptoms, and giving them instructions to quarantine themselves. And then you have to follow up with the cases and the contacts to make sure they're getting along, how they're getting along with the isolation and quarantine, how are their symptoms, how are things going. So it's really a relationship with people throughout the isolation and quarantine experience. I just want to highlight how important it is to build rapport in contact tracing. So all of this is about behavior change, essentially, right? And so that's never going to happen unless there's trust. Of course, there has to be trust broadly within the community. It's not the job just of the contact tracer of building that. That would be ridiculous. But they do have to be good at building rapport with cases and contacts, both to give the information that cases and contacts need, but also to get the information that they need to do their job and find contacts and let them know they've been exposed. It's also really important part of a really important part of contact tracing is identifying cases that could be at high risk for sort of super spreading events, or people who have been in or who live in settings where risk of transmission is really high. Congregate housing settings is one example. Other high-risk subpopulations that have increased risk for severe disease is another example. And so when contact tracers are talking to cases and contacts, they always need to be on the lookout for this. So anyone who's in a very dense contact environment, or people who are difficult to, can't identify their contacts or easily identify who they've been exposed to, people who have difficulties with isolating or quarantining themselves, and people who are at higher risk of severe disease or death. And just, I'll go quickly through some of these, and you could look back if you want, but if you've been around a large crowd of people for a long time, so like at a sporting event or a concert, and that's why, those types of opportunities now really, a lot of places are not allowing those because of this risk. There are other, again, scenarios where the contacts may be difficult to trace or identify, or exposure is difficult to identify. And some examples of that could be, for example, in a homeless shelter, where people may not know the people they've had contact with. The contacts may be spread out in multiple jurisdictions, and it could be difficult to test or find people who've been exposed. There's also places where it's difficult to isolate or quarantine, or where people are unwilling to cooperate to do that. One example where it's difficult would be an intermediate care facility. So residents may be unable to cooperate. They may not understand concepts of hygiene. It may be difficult to remove people from that setting because they need the care. So these are the types of places where controlling spread of COVID is just really difficult, and takes even more effort above and beyond regular contact tracing. Let's talk briefly about some ethical considerations. This varies from country to country, but in the United States, many people are worried about contact tracing programs because they violate their privacy or confidentiality or their rights in some way. So it's important for people to understand really these concepts, and it's important for contact tracing programs, to communicate clearly how they respect privacy and confidentiality of others. So private information is information about your personal life, right? And contact tracers have to ask about this as part of their job. So they're going to ask things like, who lives with you? Who did you spend time with last week or during your infectious period? Where have you gone out in the past week? How much time did you spend with people in your home or outside your home? So this is some private information. So contact tracers ask about private information, but only for the purposes of contact tracing. and they can use the information only for the purposes of contact tracing. So that's important just for the general public to know. The same is true for confidential information. So the difference between private and confidential information is that confidential information includes your medical information. So they will be talking to people about, they'll know your COVID-19 test results, right? So that's an example of confidential information that they'll have. They may ask about your other health conditions that might put you at higher risk, because they may give you different medical advice about when to seek care. So they'll be asking about some medical information as part of their job. But again, they can only learn about that, and they can only use it for the purposes of contact tracing to try to help keep people safe. And it's important to remember that we always have to balance public safety with any kind of intrusion into someone's private life or medical information and their autonomy. And so we have to be convinced that contact tracing programs really are a public good for this purpose. So just in case you get questions about that, or maybe some of you have questions, we can talk about it more even on this call. But this is something that people in the US are concerned about and talking a lot about. So it's good to have open discussions about it. I also want to talk briefly about some technological tools. This is something that's also been getting a lot of discussion. And I just want to say broadly that, when we talk about technology and contact tracing, there's so many different examples of how technology can help. And again, the speed at which we have to do this is unprecedented. So we have to use all the tools that we have available to us to make this happen. But I think it's important whenever we introduce some technology, we have to be convinced that it's going to solve an actual problem that we have, and that the solution or that tool doesn't create any bigger problems than the one that we're trying to solve. So just as an example, like electronic case reporting is an example of technology that helps with contact tracing, right? So when a patient gets a COVID-19 test, that goes into an electronic system. And then there's a central database where the public health department can pull that test result out as a part of contact tracing programs. And the faster that is, the better it's linked with other data sets. It's automated. It makes it easier and saves time if this is all in one electronic database. And it gives you, it means that there's less time between the diagnosis and when the public health team can act. So this is one example of tech. Another one is, I'll just say briefly, is tracking symptoms. So again, you have to follow up with cases and contacts every day. There are some apps that you can use. So instead of calling them every day, you could just text them and say, hey, how are you feeling today? Any new signs or symptoms? It's a little less invasive, takes less time, and people may like it better. So this is another way tech could be used. But there's a lot of there are a lot of ideas about technology also that can be used to identify people who've been contacts. So I want to run through what some of that looks like. That's not being used in the US right now at all. And it's important to remember that even where it is being, well, not everywhere, but in places like Australia, where these are being used now, the sort of Bluetooth identification of people you've been near is all opt-in. So in order to participate, people have to download the app themselves. So it's something that people are opting into, but again, it's not currently being used here. And I think there are some difficulties, I think, with using it and how it plugs into a healthcare system. If you download the app and it keeps tabs on who you've had contact with, it can let them know immediately. But just because you get a text message saying you've been exposed, what do people do with that information? How does this link up with a public health system? All of those details really have to be clear and worked out. And I think there are ongoing conversations about this, but I just wanted to make this audience aware of what those tech systems look like in case you're interested. And there are some concerns, I've written them here, but just to run through what it looks like. So let's say everyone has downloaded the app. You're at home. It's saying, yes, the people you live with, you have contact with, physical contact probably. The people you are close to, either on the train commuting or while you're at work or while you're, when you come back home, your phone and their phones are all logging that you've had contact. It's not logging who the other person is, but it's the app on the phone is saying, yes, you've been in contact with whoever this app is on this other phone. If you develop signs and symptoms, then, and assume you get a COVID test, you could put into your app that you have COVID. And then what would happen is that everybody here who has been close to you would receive a message saying, you should quarantine yourself for 14 days, you've been exposed. So that's just basically how it works for folks who are interested in thinking about that. So in summary, contact tracing is very difficult, but it's the best strategy that we have right now for stopping spread in the community of COVID-19. It's not all or nothing. So even if you can't prevent all infections, it's still worthwhile, I would say, because even preventing a few infections could have a big impact on total disease counts in the community. It's very difficult work. It's all about people helping people. And so everyone has to buy in. It's really a community effort. That will be most successful, again, if you are speedy and you have the trust of the community and respect for human rights built into the program, like any other public health program. So I will stop there, and I am more than happy to take questions.
Thank you so much. That was a great talk, and I really appreciate you touching on the ethics of contact tracing as well, especially in a modern day and age of data security and concern. We have some interesting questions, so I think we'll start easy. The first question is from Pranav Chatterjee, and his question is, what percentage of potential cases or contacts refuse to even take the calls or provide information in your experience?
So I'm not a contact tracer every day, okay? I've done a lot of field epidemiology. I spent most of my career in Bangladesh, and I'm a researcher. So I know about how these programs work. That is totally depends, okay? Everything happens within the cultural context of a particular community. And so who decides to participate, and what proportion decide to participate is something that varies by community, and it also varies over time. And it's a function of how much people trust the system and how much they understand. And things like, even just silly things like, do you have one number that people know when who's calling, right? Does the health department have one number, or have you publicized that number so that people feel good about picking up and they know what's gonna happen if they pick up the phone? Do they understand? So there's no one number, but again,
how do you deal with that in contact tracing? Has there been some strategies developed to capture those people missed, or imputations?
So if people don't want to participate and they don't answer your phone and you can't find them and you can't tell them that they've been exposed, then many of them will go on to infect other people, right? You can't, this isn't, you can't, force people to say. So again, that's why it's so important to have community buy-in and be talking with community leaders about the program. But again, you don't have to find all the contacts. You don't have to find all the cases for the program to be successful at reducing transmission. So I think that's something that we just have to remember.
Thank you. And then reminder to all of you guys listening, if you could just please put your questions in the Q&A function, not the chat, that would make it much easier for me to track them, as I have two parallel lists running. Just another question from Indonesia. How do you deal with a dishonest person when doing contract tracing?
Well, how do you know they're dishonest? All you know is what they've told you. Again, why is someone going to lie? You have to try your best to build rapport, to make sure that they feel safe in telling you the information that you need to know. And you do your best to get the best information you can, and you act on that. That's the best you can do.
Harshad Sangvi asks, should we encourage those who are at greatest risk of infection, i.e. healthcare workers, to maintain a daily contact list as a routine so they already have a contact list if they become infected?
I mean, I don't see any problem with, helping people to help the contact tracing system, right? To think about who you're around. That's one way to do it. I think asking people to wear masks when they're out, when they're in enclosed spaces with other people that aren't their household members, is a huge strategy because if you've done that, then you haven't had contacts outside your home, right? Right. Because those, people that you've been around when you're wearing a mask wouldn't be your contact. So, there's a lot you can do to try to help contact tracing out, including reducing the number of contacts you have.
I would say as a healthcare worker who routinely is in the emergency department, it would be impossible. Like, it's so stressful and high burnout being in a clinical environment, treating the high volumes of very sick patients, especially with all the other things we've talked about in the series, so the PPE shortages, the donning and doffing, your masks, that having a pen and a paper and a list would be near impossible for me to manage. But I think early education about healthcare worker isolation, so they don't go into the clinical environment again, expose people, it does make a lot of sense.
Yeah. And maybe, I assume they would be talking about your non-work contacts, but I may be wrong about that.
Even that's like difficult, because they're just long days and the stuff before and stuff after. Is the Apple app that you mentioned easily accessible and downloadable?
I don't know. I don't think it's being used in the US at all, as far as I know. If I'm wrong, someone can correct me. But I think there are just so many concerns about how it works. Even, let's say that you are wearing a mask everywhere you go. Or the people you've been around are also wearing masks, but your phone, how does your phone know that? Right? So there's the possibility that you are a contact of when it's not actually an infectious contact. I haven't seen good data to evaluate how the app works and actually identifying infectious contacts. And I think when you ask people to quarantine themselves, it's a huge ask. It's a really big ask. They have to change their whole lives. So we should be confident that, we're asking them to do that because they really have been exposed. So I personally, just as a researcher, I'd like to see more data about how it works. And again, it has to link up with the formal public health system. One of the things that people like about this is that it just shares information with other phones, and no one is, there are no names or anything involved. But the problem is the public health system still has to do their due diligence to find contacts and trace them. So if it's not helping the public health system do its job, then how helpful is it really? I'm not sure.
From Millie Kayongo, can you clarify why the window for contact tracing is just 5 days? And then in relationship from Abel Natungi, when does someone stop being infectious?
Okay, so the window of 5 days is not, that's not right. So maybe let me just go back to that slide. So the slide was showing, so right after people are exposed, they can start to become infected, right? So we've put like the medians on this slide, but it's happening on a continuous basis, right? Most will happen around 5 days, but some people aren't infectious until out at day 10 or 12 past infection. So what this window of opportunity is showing here is to catch most of the contacts before they're symptomatic. You actually have a window of opportunity of 3 days after those contacts have been exposed. So that window is about 3 days. But that window lasts for a long period of time. People will keep becoming infectious for up to 12 days. So that's why it's not all or nothing. It's not like if you can't find everybody within 3 days, just forget about it. That is not the point. You should keep trying, okay? You should keep trying to find people. And if you find that contact and they're already sick, well, then maybe you consider them a case and you start the contact tracing from then, right? So it's a way to help limit the spread, but also to find new cases in a very targeted way, because you know these people have already been exposed. So it's not all or nothing. There's not one day where, okay, you do this day, you know, if it's after this day, it's not worth it. Don't have that as the take-home message. It's not all or nothing.
But Emily, as a follow-up, that say if you had limited resources and you could only focus for a certain amount of time, where should the greatest focus be? Would you continue trying to do this for every day for the next 12 days, or would you say, okay, we should move on to the next person because we're running out of people and staff?
So really important here is to remember that not all contacts are the same, okay? In one of the first studies that came out of South Korea, they followed 30 people and all of their contacts. There were like 2,000 contacts, these people, okay? This is totally daunting. So it was anyone that they were near for even, you know, a few minutes. Of those 2,000 contacts, there were 12 new cases, 12 secondary cases. Of those 12 secondary cases, 9 were household members. Okay, so there were only 190 people who lived with those 30 cases, right? So if you can't find everyone, you know, you should always start with the people who have the most exposure. Those are the people they live with. Those are the very close contacts, significant others or family that they've been with, you know, who don't live in the home. If you get those folks and find those contacts and get them to quarantine, you've done most of the work already. And then I would suggest working out from there. And, you know, when you're talking to the case in the first place, they're with all their household members. So it's usually pretty easy to get those people and to help them do what they can to stop spread in the house.
I think 3 more questions, if you don't mind. Bear with us.
No, not at all. Not at all.
Joe and Bennett ask, given the timelines, should we be identifying contacts of contacts even before we have their test results?
Does your program have the bandwidth to do that? That's a huge lift. I wouldn't focus there. I mean, what would be the rationale for doing that? The rationale would be that you're getting to them already too late. So you're going to try to find the other contacts. It probably makes sense to try to find them earlier and use your staff for that. If you're already finding them late, then that means maybe your program doesn't have the bandwidth to do that. And again, most of the contacts are not going to, you know, let's say, right, each case is going to infect on average 2 to 3 people. If someone has 20 contacts, you're going to be finding all of their contacts also. It just multiplies very quickly. If that's the best strategy you have, okay, but there might be smarter ways to do it.
I think there's 2 further considerations here. One is the characteristics of the test. So rapid testing would be ideal here, right? So the delays in testing that are 72 hours plus, I think are problematic, right? And so the rapid point of care tests that are now becoming more commercially available might, help with this problem. The second is high priority contacts. So again, we go back to that discussion about early isolation when people are symptomatic, not when their test results are positive, right? Because that gives you that extra 3 days where they're decreasing their contacts. So I think it's a multifaceted answer.
Yeah, I would really like to see clinicians getting involved. I mean, you know, traditionally this is a public health function, but as you say, like test results take time. Not all contacts are the same. So let's say that a patient comes in for a test. They're suspected enough to get a test. At the time when the sample is collected, if they can talk to that person and get them to isolate at home, get their household contacts to quarantine themselves while they wait for the test results, that can have a huge effect on the impact of a contact tracing program, because you're getting ahead those first few days with the people who are at highest risk for infection. And then if the test comes back positive, public health can pick it up from there. If the test comes back negative, okay, then you can go about your life. I think if we could do that and get that integrated into the system, that changes the prospects a lot.
So 2 more questions. One from Millie Kayongo. What are your impressions about the use of community healthcare workers in contact tracing, like has been done previously for other diseases such as Ebola and TB?
My impression, I mean, you have to use the resources that you have. Healthcare workers could do that, sure. Again, this all has to happen within a cultural context. So you have to think about, in your place, is this a good way to do it? Is it safe for the workers to do it this way? You have to come up with your own guidelines. But in many places, it's an actual home visit that is the best way to do it. So yeah, no problem using healthcare workers.
And I think last but not least, we're getting a lot of questions from India, which are around, high density populations. And so, what are your thoughts on the super spreader phenomenon? And also, what are some of the strategies for high density populated areas such as urban slums, with, even despite contact tracing, physical distancing is difficult?
Yeah. So the purpose of contact tracing is to get people to change their behavior so that they can isolate themselves from others and their household and their community. If it's a community where that is not feasible, then you need to come up with something else. There in many countries, so where that's not possible, you can set up an alternative housing space. So when people are infectious, or maybe a place where a family could go and quarantine somewhere else, where they have, access to their own toilet, they can get food delivered to them, or a place where they can do that. But this all hinges on, contact tracing only works when people can realistically stop contact with other people. And there are many places in the world and settings where that is not possible. So you have to think about ways to make it possible if you want to do this.
Can I ask one more question, because I think it's interesting? Have you seen any instances where contact tracing is integrated with the electronic health system, or with the electronic health system?
Integrated into the, can you tell me what you mean by that?
So is the contact tracing, is there a contact tracing system integrated with the regular health information system, or are they often separate independent entities?
So that really varies. In some places, everything about you in the whole country is linked to one ID. And so people link up cell phone records, test results all into one database, and it's all there. The US is totally different from that. There's, like, for example, in Maryland, there's one system for the state where all COVID test results go. But then results have to get out of that system into a different system and software for contact tracing. And so there can be some, sometimes there are bottlenecks, or there are difficulties with moving the information from one system to another. So it's very context specific, but the faster you can make that, the better it is from the contact tracing perspective.
Thank you so much, Dr. Gurley. That was an onslaught of questions that you just had to deal with. There is a lot of questions, friends, around testing. What does it mean to have IgG? Is reinfection possible? A lot of these I didn't answer because they remain somewhat unknown. What we'll probably do in the next month or so is invite our serological experts, Yuka Manabe and Dr. Thomas Quinn, to maybe give us some of the latest information on how we're thinking about antibody testing as it relates to immunity. and also the chances of reinfection. But with that, I would like to close the session and say thank you.
Yeah.
Next Thursday, we have a really, really interesting topic. We're transitioning a little bit from COVID-19, but to the other consequences of the COVID-19 pandemic. And so we're going to be talking about gender-based violence and intimate partner violence in the era of COVID-19. And we hope to inform you of some of the strategies that have been adopted at national levels to prevent or protect those that are vulnerable from gender-based violence. So thank you so much for joining us, and we'll look forward to seeing you all next Thursday. Have a great day.